So welcome everybody. I think I know most people here, but my name's Brian Williams. I'm the Deputy Principal Academic and Research at UHI. It's a real privilege this evening, not just because it's always a privilege to be chairing an inaugural lecture, but to be honest, it's a real appreciation because this is a topic area and a subject area I've known well and inhabited for quite some time, most of my career. So I'm going to make a few comments. Hopefully I'll try and embarrass Nicola a little bit, but I just appreciate what it's taken for Nicola to arrive at this point as well. And I would like to say a few words about that. But a very warm welcome to everybody here at UHI House today. We're delighted to have you to join us on this special occasion as we celebrate Nicola Carey's inaugural professorial lecture, Innovating Healthcare. Whether you're here in person or joining us online, thank you for being part of the event. We do have a few housekeeping rules just to mention. There are no planned fire alarms today. In the unlikely event of an alarm, please follow the guidance of UHI staff. We'll exit through the main entrance and assemble at the designated muster point in the car park. Restroom facilities are located just outside the auditorium. Turn left on exiting and you'll soon find the marked doors. After Nicola has been speaking, we will have a Q&A session and then we'll have a networking reception outside. So it's a wonderful opportunity to do a bit of networking and to talk with other colleagues. There'll be some good Highland food served up with a selection of curries, alcoholic and non-alcoholic fizz. And for those attending in person, if you do have any dietary requirements, please check with them directly. And finally, please be aware this event is being recorded and photographed for future sharing on UHI platforms. So if you don't want to be featured, please kindly inform a member of the team. So once again, thank you for being here. We do look forward to an insightful and inspiring evening ahead. No pressure. Okay. So just a few words. Nicola and I think we arrived almost at the same time in UHI. I have to say, having worked with the nursing and AHP community, particularly in facilitating research over about 20 or 30 years, I have a huge amount of appreciation for absolutely what it takes to get to this point. Being an academic is never easy. Being a research active academic and preserving that and building it is never easy. And doing that in the context of the nursing profession, where perhaps an easier life could be taken elsewhere, is never easy either. I'll say one or two more words about that. But my first impressions about Nicola were, this is a woman who knows her mind. This is a formidable woman. And I think we'll get on great. So I think it was clear that Nicola had a successful clinical career, community nursing, but she knew her mind. She saw some of the changes in clinical practice that she wanted to achieve. So innovation and impact was what she wanted to achieve. And throughout any conversations, nobody was going to stop her from pursuing that. I think those are recurrent themes throughout her career. And can I just say at this point that research is a tough gig. It's getting funding in all the time. It's looking at different contexts. It requires a level of resilience you keep on submitting grant applications time after time. They turn you down, and it's that level of self-belief. However, research within the context of nursing is even more difficult. It's not to do with the profession. It's actually to do with the fact of what you deliver. Now, I'm sure if I'm going to get myself into trouble with one or two folks here, but I've worked for many years in health technology assessment and evaluations. If I take a pill or a tablet or a medical device, I can see it, I can count it, I can define what it is. If it works in one clinical context and I can shift it to the same patient group in another context, it will probably work. Within nursing, very often that's not the case. These are highly complex interventions. It's not a noun, it's often a verb. It's what you do. and it has to be context dependent. If you pick it up, you move it to somewhere else, it might not work. How do you evaluate something like that? So the sort of work that Nicola has been doing over the years is some of the most methodologically complex work that we can do. It takes resilience, but in actual fact, it's so important in order to be able to deliver change in clinical practice. So Nicola, all respect to you for pursuing that over these years. I think it's testament to Nicola's persistence as well that over the course of her career to date, she's published over 80 research papers, and her work has been cited by others over 2,000 times. That's a significant contribution and a significant reflection of everything you've done. But I don't actually think innovation in terms of clinical delivery is entirely what Nicola has achieved in her career to date. We do have a challenge in nursing and the allied health professions of developing research capacity and capability. Very often we don't have the clinical pathways, we don't have the ability or the structures to financially support people in clinical practice to do more research. They do PhDs, etc. We then don't have the structures to maintain that, and people end up going back into the NHS, not having a research active role, or just doing research, just doing teaching itself. That's not to denigrate teaching at all. It's just the fact we need more research and we need that greater evidence base. So throughout her career, Nicola has pursued her heart, but she's also done what she thought was right. That's developing that evidence base and innovating. It's innovation in healthcare in the context of nursing. It's not just about new devices and processes. It's about forging ahead new roles. It's about developing new ways and being able to demonstrate that becoming a research active and an impactful academic nurse is possible. So at the heart of what Nicola has done in her research in terms of innovation, she's lived that in herself in terms of showing what is possible. Innovation is not just what you've done in terms of your research, it's actually in terms of the career you forged itself. And I think that acting as a role model and showing what's possible to others is something we should all be appreciated for. So, Nicola, thank you very much. And I'd like to invite you to come to the lectern.
Well, thanks very much, Brian, and good evening, everybody. And thank you, everyone, for being here this evening. I want to begin by saying thank you to UHI for this opportunity. To my colleagues, collaborators, friends and family, your support has made everything in this journey possible. Thank you for joining online, and special thanks for those unexpected guests that have arrived at short notice this evening, who have made a special trip to Inverness to join in person. And as you know, I come into this role not just as an academic, but as a nurse with a background in practice nursing and being an advanced nurse practitioner. My early experiences were based in Newcastle upon Tyne, and that's the place where my commitment to innovation was born. So this moment isn't just about professional recognition. I'm here to talk about innovating healthcare, but from a nurse's point of view. I want to explore what it means to change things, not just with technology, but everyday innovations that transform services, empower healthcare professionals and improve lives. The ones that rarely make the headlines, yet define the reality of healthcare delivery for millions of people. For me, it's a chance to take you through my journey from the early days of hospital nursing to the university setting, my trip around the UK and to the US, sharing the work that I've done, the ideas I believe in, and maybe even a few lessons that I've learned along the way and where I believe that we're heading. So whether you're here out of curiosity, support, or because someone promised you free food and fizz at the end, I'm genuinely glad that you came, and let's get started. So how did I end up here today? Giving a lecture about healthcare innovation. Like most things in life, it wasn't a straightforward path. I didn't grow up thinking I want to be a university professor. I was more interested in leaving home, having my own room and moving to the bright lights of the city, which at that time was Newcastle upon Tyne. Reflecting on my early childhood, I was the third out of 4 children, and I was thrown into the art of negotiating and learning how to have my voice heard from a very early age. My interest in healthcare also started at an early age. I took experiential learning very seriously, becoming an early and frequent user of the NHS. Having multiple generations of nurses in my family, including my mum, going back for over 100 years, all of whom were trained and worked in London, supporting efforts in Ceylon and Belsen at the end of World War II, meant a serious illness or accident had to be declared before a third-party intervention could be sought. And I clearly worked hard to reach this threshold, clocking up several broken bones and injuries that warranted hospital attendance during my childhood years. I was an innovative child. I had to be to get my voice heard, not in the way that meant winning lots of awards, but that meant asking why. Why does it work like that? And more often, why can't it be different? Now, not all innovation will be successful. Some of my more notable early interventions include making a pirate ship out of bunk beds, making birds' nests out of cut grass, and rock cakes with a pound rather than an ounce of custard powder, where even the birds wouldn't eat them because they were bright yellow. So they sat in the garden for a few weeks before they were binned off. Now, one of my most successful early innovations was in the guides, when during one of our regular meetings and in close inspection of the Girl Guide handbook, I saw there was an opportunity to become known something more than the Swallow Patrol. And after much impromptu broidery, a new patrol was born. And much to the annoyance of the guide leader, who couldn't find a reason to say no, we soon became known as the Pineapple Patrol. Her irritation rose even further when the Snoopy Patrol emerged soon after, and that was led by her daughter. So my interest in nursing started quite young, and I remember a poster that my mum brought home from work from the local GP surgery where she was based as a district nurse. It had a picture of a rotting cabbage on it with a message, "Don't be a cabbage all your life, get up and exercise." So over the years, she did bring back lots of posters from work that me and my sister would put up in the bedroom. Why you would do that, I'm not quite sure, but I still can see the image of a cabbage, vivid green. I remember thinking, why is a cabbage sat on a chair? And why would anyone sit on a chair and let their life rot away? So surely there must be something that can be done to help people who are sitting in a chair all day. So my journey. Although my nursing journey now spans 40 years, I can still remember being dropped off at the RVI Nurses Home in Newcastle on a cold and wintry February afternoon, having the pep talk from my dad not to do anything silly. Now, not so long ago, when we were clearing out my parents' house, I came across a letter that I'd written a few days into my nurse training back in 1985 that my mum had kept. And I reported that so far, and this is at least 4 days in, it had all been about the nursing process. Activities of daily living, which even after a few days I declared seem like common sense, along with the essentials of hat making and surviving with one cooker between 300 people. And I look back at the early days and the joys of keeping food fresh in a plastic bag hanging out the window in the nurse's home with misty eyes. So during the early days of nurse training, and then as I progressed into my first job, I started to notice gaps between what we were being taught and what was the reality and what was deemed best practice. I discounted opportunities such as ITU and places where patients were generally asleep. I was generally more interested in talking to people who were awake, and I settled on a dermatology ward and enjoyed the opportunity to listen to patients and support them through the many weeks and sometimes months of treatment for their skin conditions. Soon after, I moved into midwifery and had the opportunity to support women and their families before, during, and after pregnancy. Even in those early days, I was attracted to the increased level of autonomy and decision-making that those settings seemed to allow. Once I started, I realised pretty quickly that nursing teaches you to notice things. You learn an awful lot in the early days, a bit like after you've passed your driving test. Not just how to do a bed bath or to change a dressing, but how to care and care properly, how to listen when people aren't saying very much, and how to stay kind. At some point, you begin to appreciate and understand that the system isn't perfect and can often fall short, how one missed detail can change everything, the importance of asking questions, and the importance of asking difficult questions. I started asking questions, bigger ones, like, why are we still doing it this way? Who's making these decisions? And why are the people who actually deliver care, i.e. nurses, not the ones shaping the system. So back into the 1980s, before the advent of memory foam and other pressure relieving devices, ring cushions were all the rage. And then these were like really proper solid items, and patients were asked to sit on them to help relieve pressure. But I'm sure I'm not the only one here that can remember they seemed to work in the opposite way, and patients often had a ring imprint on the bottom. So different encounter number 1 followed soon after, as we'd been taught that these were deemed now less beneficial than originally thought, and other options should be considered. So I chose to challenge their use with the long-standing dermatology ward sister of the time. And it was the first of many challenging conversations I had with her about the use of evidence to inform nursing practice. And it will not be a surprise to any of the nurses here or online that this conversation did not go well. And it was the start of a long and enduring tense relationship, as I was simply classed as being newly qualified with more knowledge from a textbook than could be considered useful on a ward. It was the first of many similar encounters over the next few years. This was a busy and transitional time for nursing and nurse education as it moved from traditional schools of nursing into the education setting, where newly qualified nurses joined the workforce with a diploma or a degree. Now, I wanted to be part of that journey, and I didn't want to be left behind. And along with many others of the time, I completed a steady flow of courses and qualifications, studying long into the night, weekends and holidays to get me to the point of having a degree. At the same time, I had a steady flow of jobs, from undertaking occupational health screenings across the UK, bank nursing, practice nursing, and being an advanced nurse practitioner. By this time, I knew what I did and didn't want to do, and I had strong ideas about nursing and healthcare from the various places and settings where I worked. I simply didn't understand why so many nurses would simply do as they were told, particularly if they were asked to do so by a doctor. Having the opportunity to live and work in the US for a couple of years, undertaking my master's degree alongside teaching a range of health-related classes to young Americans was a pivotal moment. Following another pep talk from Dad, who reassuringly told me that if it didn't work out, I could come home, arriving in the US for the first time with 2 bags to my name, being bold and innovative came into its own. Soon after arrival, I was advised that I'd be leading a class of more than 50 students, responsible for everything, developing the content, doing all the assessments, doing all the marking. And oh yes, the class starts in 2 weeks' time. So the very steep and often painful learning curve I experienced while trying to navigate and comprehend this whole new system of education and healthcare was a real eye-opener moment. But here's where my grand plan to do something with all the insights I had collected started to gain traction. This curiosity, and let's be honest, frustration in having a lack of voice, is really what pushed me towards research and education. I realised that I desperately wanted to be involved in generating evidence to inform nursing and healthcare practice. Meeting with and learning from senior professors in the US and other students, my experiences showed me how it could be done, what I needed to do next, and it instilled a newfound confidence that I actually could really do this. Being able to help future healthcare professionals ask better questions, think more critically, and maybe even realise that they too can challenge the status quo is still one of the best decisions that I made. So what does innovation in healthcare really mean? So innovation for me, it's not about novelty for its own sake. It's about starting with the individual, the needs and preferences, and working in partnership in creating solutions. It's about aligning what we know works in theory with what's possible in practice. And it's about making sure that frontline nurses, along with other health and social care professionals and policy advisors, have all the tools, evidence and support they need to improve outcomes. Now, over the past 20 years, we've seen remarkable advances in medical knowledge and healthcare research, but too often these fails to translate into day-to-day practice. The reasons are complex: organisational culture, policy inertia, resource constraints, but the result is simple: missed opportunities to improve care. Implementation science helps us understand why evidence-based interventions succeed in some settings but not others. It's where a lot of my work has focused, identifying the barriers and enable us to change and co-designing solutions with the very people that will use them. One of the most striking examples comes from my work on prescribing, not just for nurses, but all the other professional groups who have prescribing rights, including paramedics, pharmacists, physios, podiatrists, radiographers, dietitians, and optometrists. It's taken nearly 30 years of policy development, education reform, and professional support to implement. But today, multi-professional prescribing is transforming care across a wide range of settings for people with acute and chronic diseases, improving patient access to timely care, particularly in underserved areas, including remote, rural, and island locations. And I'm proud to say that 4 million prescriptions are issued by this group of healthcare professionals each year, reducing NHS costs by £160 million each year. And I'm proud to have been part of that journey. This, to me, is innovation. This is systems change rooted in evidence and delivered through collaboration and a good amount of tenacity and perseverance. Healthcare innovation must start with people who receive the care, not the products. Whether it's rethinking how services are delivered in primary care, supporting digital literacy in patients, or expanding the scope of healthcare professionals, the key lies in understanding context. In our studies on prescribing for long-term conditions, we've seen how small changes like nurse-led consultations, supported self-management, or multi-professional teamwork can lead to measurable improvements in patient and service outcomes. But these changes can only succeed when professionals have the right knowledge and skills and systems are allowed to support innovative models of care delivery. Engaging with policy is critical. Evidence alone is not enough. As researchers, we need to work closely with commissioners, regulators, and decision makers to ensure innovations are scalable, sustainable, and relevant to local needs. In a world where healthcare systems are under increasing pressure, the need for accessible, efficient, and personalised medical care has never been greater. So let me tell you another quick story. It's like having a doctor in my pocket. That's how one of the patients at Hospice Ethiopia described their experience of using the AZAT app, a mobile phone application developed to support palliative care in Ethiopia. It's a simple sentence, but speaks volumes. For that patient, the app meant not just access to information, but to dignity, relief, and a sense of being cared for, even from afar. A few years ago, I was part of a team that developed this app. It wasn't a straight path. The ideas emerged over several years, many long meetings, and multiple failed attempts to secure funding. But despite the setbacks, our international team from Surrey, Strathclyde, Hospice Ethiopia, and the Federal Ministry of Health stayed committed to one shared goal, improving access to palliative care in a country where the need is great and resources are scarce. With only one hospice and severely limited palliative care service, the majority of the 110 million people who live in Ethiopia do so in rural settings, far from the limited support available. Partnering with an Ethiopian software developer, we co-designed the AZAT app to be used not just by healthcare providers, but by patients and families themselves. The app provides support for managing pain and symptoms, wound care, emotional well-being, and spiritual concerns. And during the short testing phase, the feedback was encouraging and moving. Carers told us how the app changed the way they cared for their loved ones. Some described how it helped them reach their spiritual fathers for comfort and guidance. Health professionals recognised the potential of the app to support targeted care with limited resources. And more importantly, patients reported feeling more reassured, more supported, more seen. Innovation doesn't always need to be flashy. Sometimes it looks like a phone app designed through collaboration, cultural sensitivity, and a shared belief in equity. The AZAT app is a small step in addressing a big gap, but to that patient, it felt like having a doctor in their pocket, and that's what innovation in healthcare is all about. So what now? We're at a turning point. Healthcare systems are stretched, staff are exhausted, patients face inequalities that go far beyond clinical need, and finance is a massive issue. But within this challenge, there's also opportunities. There's opportunities to redesign services that work better for patients and staff. There's opportunity to embed equity, not as an afterthought, but as a starting point, and an opportunity to involve people in shaping the care that they receive. Innovation isn't optional, but it must be person-centred, and that's where nursing can lead. Nurses occupy a uniquely powerful space within the healthcare system. We're closer to patients than any other profession, providing care, listening deeply and building trust. We have a clear view of the flaws. We can see where care breaks down, where inefficiencies harm, and where simple changes can transform outcomes. And yet, we are still too often excluded from innovation efforts, strategic planning, and policy development. So where do we go from here? If there's one thing that healthcare doesn't need, it's more ideas. It needs more courage to act on the good ones that we already have. As a country, we've spent millions, if not billions, over recent years of taxpayers' money on high-quality research. Decision makers need to take a look at these outputs. We already know that patients want to be heard, that staff want to feel valued, that systems run better when people are supported to lead from wherever they stand. The question isn't what to do, it's why aren't we doing it yet? So here's where I'm at. Let's stop waiting for someone at the top to tell us how to improve care. Nurses and other healthcare professionals, support workers and students, we're all closest to the problem. We see them every day. Let's support the frontline workers to shape the solutions. Innovation should start with a tea break conversation and a have you ever thought moment. I want to see a future where leadership isn't about hierarchy, it's about listening and acting boldly, where nurses have a seat at the table, not just the patient's bedside, and where academics are co-creating change with practitioners and communities from the start. Let's normalise asking why without fear. Let's make it okay to say this doesn't work without being labelled difficult or negative. It would be great to see a system where curiosity isn't seen as disruption, it's seen as care. As a researcher and educator, I want to light the fire in the next generation and enable them to question the status quo, to recognise themselves as change makers, because innovation isn't a title or a department, it's a mindset. At UHI, we have a unique position. Our geography demands innovation. Our communities deserve it. In our remote and rural communities, like many in the Highlands and Islands, person-centred, flexible and accessible care isn't a nice to have, it's essential. We know the reality of delivering care across distance, diversity and infrastructure gaps, but we also know the strength of community, collaboration and creative thinking. UHI is a place where interdisciplinary work flourishes through education, health and community. It's also a place where research can directly impact lives. So before I end, I want to leave you with this. I came to nursing and this role ultimately inspired by the image of a rotting cabbage and a belief that it must be possible to do something to help people get out of the chair. My experiences have shown that it is possible to do so. But innovation isn't always loud, it's not always obvious, and it's rarely convenient. Sometimes innovation is a nurse or a healthcare professional saying, this could be better, a student asking, why do we do it that way? Or a patient whispering, thank you for listening. These are small moments which I believe will shape the future of healthcare. They may not be the loudest voices, but they will be the most consistent ones, the ones that show up, speak up, and try again. I'm incredibly proud to be part of that work, to be a nurse, an academic, a listener, a challenger, and above all, a believer in better. A believer in helping people get out of the chair. I'm excited about what we can build together here at UHI and beyond. So thank you for believing in the power of nursing and innovating healthcare. And thank you for being here tonight.
Okay, I think we've got a.
Hold on, take that.
There you go. Have some time for some questions now, so I think we're going to be open it up to the floor. We have 2 roving microphones. I wasn't sure about the online. Yeah, okay then. So we'll open it up. Any questions for Nicola? Yeah, Steve.
Hi, it's Steve Leslie. I'm one of the cardiologists across the road. That was inspirational. My question is, how do we inspire young people to get into nursing?
How do we inspire?
How do we inspire young people to come into nursing? I think that's one of the things that I see that we're struggling to fill, get cabbages and seats. And
New marketing campaign.
This is it. Yeah. I don't think there's an easy answer, is there, for that? I mean, it's sort of multi-pronged, multi-societal, about making it an attractive option, isn't it? And, you know, there's so much media influence on people's thinking. It's pervasive that you don't even notice it. So it sort of comes from changing the mindset. But yeah, it's a tough journey, isn't it, to get people to want to come into healthcare when there's so many different opportunities available that seem easier.
Any others? I do have one I wanted to ask, but I'm just waiting for somebody else to. No? Oh, Sue. Yeah.
Sorry, jumping in front of you, Brian. Thanks very much, Nicola. Yeah, there's an awful lot to think about. I'm thinking about the education aspect that you spoke about and encouraging people to challenge and ask questions. And I'm wondering how you go about that in a nursing program where you've also got the standards and the quality. How do you balance that? You know, this is the way we do it. This is best practice, and the opportunity for people to learn to challenge.
It's the culture, isn't it? So it's the culture of the NHS. It's the culture of nursing and healthcare. Not to see it as derogatory, to be asked a question, and to be challenged. And you know, I mean, it's not a perfect system for sure, but you know, we have to start somewhere. And, you know, I'm looking back on 40 years and I hear the same things happening in practice now. And it's, you know, it's disappointing, but, you know, one hopes that there's progress being made. But, you know, it's up to us, isn't it, to instill the confidence in students to be able to do that.
Thank you. Okay, I'm going to put in with a question first before anybody else up here. Nicola, it's occurred to me over the years that within the nursing communities, innovation is so much part of the job. And when we look at, let's say, over the last 10 years, say quality improvement has sort of moved itself through the NHS. So many nurses at the front line are innovating all the time. They're seeing the problems and they're using QI methods now to address some of those frustrations, try things out. If they don't work, try them again. And there's this sense in which there's a story that's not being told necessarily there, or we've separated off the innovation that's happening within QI and the nursing communities from what's happening in universities with a research label. But it's problem solving, it's what the profession is about, it's what great nursing is about. And so for innovation, do you see, are there ways about bringing these communities together? And perhaps it plays to Steve's point, that actually there's so many good stories. They're not sitting just in the university or just in the NHS, that they're there. We're not saying them. Is there room to bring innovation back together across both communities?
Well, of course, well, definitely there is, isn't there? It's about understanding what everyone's doing, isn't it? And I think we do try. And for me, though, it doesn't have to be, as you were saying, it doesn't have to be a big thing. It's about giving people the confidence to be able to make the change without making it a big thing. You know, asking the ward sister or the person in charge. You know, you're almost not asking for permission, you're almost seeking forgiveness. You know, so it's having that confidence to be able to do that without fear of reprimand. And I don't think we're really there yet as a culture within nursing.
So much about empowerment.
Yeah, I think so, yeah.
Okay. Great. Thank you. Yeah.
Oh, sorry, the mics. This has come back. Yeah, that was really good. What I want to know is, as a junior nurse, and you approached your charge nurse, I know you said it was a lot of hard conversations. How did you persuade her to get rid of that donut? How did you?
Well, I don't think it was immediate.
I know that.
He was pretty hardcore as well. So we locked horns and it went on, and I had my paper printed out, obviously, that I took with me.
So you did a bit of research, or was it already? No,
it was a research paper. There was actually research on it in the 1980s, and I took it with me when she challenged that I was incorrect. I mean, she didn't like it, she didn't like it, but eventually it did move, you know, and then And then when I left, she sort of made some comment about, it's been wonderful working with you to be so challenged. Do you know what I mean? So it's, you know, so it's almost like, it was almost like she enjoyed the bants, really. But she was never going to say it to my face when I said, but when I was leaving, it was okay because she was in the clear.
Right, because I know that happens quite a lot. And you made the change, but a lot of us don't quite get there.
Well, I didn't make the change. I started the process of change.
That's true.
I started the conversation because, you know, like you want to do the best for the patient. If that's not the best for the patient, you know, I mean, I'm sure that you've seen people with these ring impressions on the bum, and you know that you just think, what's this about?
Yeah.
And you know, it's not good. It's not good.
No. No, it's just it's good to know that there is powers of persuasion in some people when there's seniority about.
Well, it's all about perseverance, isn't it? So if it doesn't happen on that day, you just have to keep going back and just keep chipping away.
Nice one.
Yeah.
Thank you.
As I said earlier, formidable.
I hope that none of my family are going to chip in at this point online. So, especially my sister, just saying.
Do we have any?
Speaking of online, folks, we've got a couple questions from in the chat there. One's from Dave asking, do you think it could be valuable for somebody who wants to work in healthcare to have experience in other industries first so they can bring a different perspective? They're starting in September and are 45, so hoping for a yes.
Is that Dave Buddle, is it? No, I don't know who Dave is. But yes, we have lots of people who come into nursing as a second, if not third career, and they have lots of different skills that they bring, which is great. You know, so I mean, we've got students going through at the moment now who've got management skills and they're challenging the NHS. And it's not always well received, as we know. So, but, you know, we have to start somewhere. And it's about both sides being open to the conversation and not being threatened. You know, it's about removing hierarchy, isn't it? And that everyone's an equal in the conversation and being comfortable with being uncomfortable.
Absolutely. We have another question in from Jane asking, where do you see your future projects in supporting such inspiring innovation in nursing?
Well, me and nurse prescribing have got a long history, so that's always going to be the epicenter of everything I do. I'm very, very passionate about nurses using, not becoming, you know, what do they say? We don't want nurses to become doctors. We want nurses to become maxi nurses, using everything they've got in their toolbox to the most efficient way that they can. So, you know, the whole thing around nurse prescribing and prescribing for all the different professional groups is, we know what all the barriers are, we know what all the challenges are, and each time a different professional group comes on, we just keep reinventing the barriers. The barriers are still there because somebody somewhere is not listening to the information that needs to understand the infrastructure that needs to be put in place to let these people maximize the roles that they have. So, you know, we have all the evidence. It's about using the evidence and people in the positions of the decision makers within organizations being open to doing something different and something new. And being, if you're the person that's making the decision, being confident, what's the worst that can happen? That you have to change it back. You know, that, you know, you might not have all the answers at the beginning, but you can only do one step at a time.
Absolutely. We have another question from Aaron. What advice, and it's kind of related to Dave's question earlier, what advice would you give to someone from a non-clinical background who is looking to build a career in healthcare innovation or process improvement?
Well, I think if you've not got a background in nursing and you're interested in healthcare innovation, probably the most important thing is to try and get some experience. And, you know, there's lots of different ways you can do that depending on your age and where you're at. You know, personally, I've had people who've worked on projects in a voluntary capacity. You can get opportunity, and I'm sure that's the same for a lot of different people as well. And you just literally looking for someone to give you, you're like a foot in the door, really. And it's making that foot in the door that's really the most difficult step. And once you've got your foot in, never let it out, of course. Yeah.
Superb. Thank you. I've got one more question from Dave Buddle. And he's asking, technical innovation is a very much focus in an AI or high-tech world. Do you also see complementary benefit in developing the human element, bedside manner, supplying levels of medical information, etc.?
Well, yes, Dave Buddle, I do, but you still need people to do the grassroots of nursing in terms of listening to patients and caring for them. So AI has definitely got its place. I'm all for AI. It's really useful and is really going to revolutionise care. But at the end of the day, if you're sick and you need support, that's got to have the human impact factor. It's got to have the human touch.
Absolutely. All right. I've got another question actually from Magnuson. They say, lovely talk. Your work in Ethiopia is particularly moving and inspiring. Are you hoping to continue this work, and could the app be used in other contexts with limited resource?
Well, yeah, I mean, I've got my colleague Nicola, who is I worked with on the project, and Roma is online as well. We're very keen to develop the app. The app definitely could be used within the UK. It has all the, I'm going to say the groundwork was done. The challenge is, of course, is scaling it up. And the infrastructure in Ethiopia is so complex, and we have tried for additional funding, but haven't been successful yet. But definitely, yes, it could be used in other African countries and in the UK, really.
Thank you very much. That's all the questions I've got from the online chat for now.
Have another question in the room?
Hi, Lizanne from NHS24 and UHI. So really interested over your digital front door, and coming from a national perspective, remote prescribing, it's really difficult. And I actually was at Strathclyde University last week raising that there's a lot of research about having robots in the wards walking beside us in the next 5 years. Maybe already there, but anyway, but how remote prescribing is really difficult from a national perspective, especially for NHS24, trying to reach out to all the different health board and regional partners, because part of that is that we've got so many barriers. We don't have a digital platform that we all share so that we're doing safe prescribing. So, and I obviously love your work with Ethiopia. So I'm just wondering, we've been so passionate about remote prescribing. Was there anything that you've come across that we could help, sharing these? It's not like patient records, but it's so that we are able to enhance prescribing, and it's all for the patient journey, but not just become prescribers, like as a clinician.
Mean like through audit? Do you mean?
Not just through audit, but it's good. I spoke to the AI, there's a big conference in Strathclyde last week, and when I asked them, can we have a digital platform, a national one, they said there already is one. But I said, well, why are we not all using it yet? And that would then be easier for us then to do remote prescribing nationally. So I just wondered where you were at with the remote and prescribing from that.
I haven't done anything in that area, but I'm always open to ideas. Always open to ideas.
Hi, Nicola. Thank you. I'm a little bit disappointed that we didn't get any pictures of young nurse Nicola today.
Oh, yes.
What would you describe as the aspect of your career so far that you're most proud of?
Oh, I'm most proud of being able to support the policy changes that have extended prescribing rights to those other professional groups. It has been a really long and incremental journey. And, I know the work that myself and colleagues have done have informed those policy changes, not just in the UK, but in lots of other countries around the world. And really, given, I think it's 350 million people short on the healthcare workforce, that's a massive undertaking. So I think there's a lot of potential.
Okay, I think that's probably all. So, Nick, I have to say, I think an inaugural lecture in this context is one of the hardest things to try and figure out how to pitch. Because it's not just about the subject matter, it's about the person. And how do you bring that in? And I think you've done that wonderfully. That mix between the personal, the professional, really understanding what's driven you over that period of time, what the storyline has been, and genuinely the number of people who've online and in the room here tonight who've used the word inspire. I think it was wonderfully eloquent, so huge thank you to you. I'd like to offer my sincere thanks to Professor Carey for presenting this fascinating for presenting this fascinating lecture, and I'd now like to formally welcome her to the professoriate, a well-deserved recognition of an outstanding contribution to healthcare research, education and leadership. We're truly privileged to count her amongst our community of scholars. So,
thank you.
Thank you.
Thank you very much. Oh, am I?
There's a lot of water right now. Okay, I think that brings things to an end in terms of this session. So I think now we're going to move outside.
Yeah.
As said before, there's some food and drink and opportunity for conversations and networking. And I think there will be a little bit of food. Okay, thank you all.
Thanks, everyone.
Online,
Thank you.
in the room.
Thank you.